Today we have a case presentation by Dr. Maunil, who is a student, and we are going to present a patient with by requested us to discuss case. Dr. Chief of Hepatology at Mahatma Hospital with us, and Dr. Shaleen Agarwal, who is a senior cardiac transplant surgeon at Max Saket. Thank you, Shaleen, for joining. Maunil, yes, start.
Thank you, sir. Would I be president of a 35-year-old male who is a resident of Moderator, Rajasthan, labeled by occupation. He was presented with the complaint of BLS and waited for 15 days and abdominal distension for 7 days. Patient was asymptomatic before 20 days and alcohol drink. Then he had been alcohol drinking, followed by yellowish distillation of sclera for 15 days, which was insidious in onset, painless and progressive, followed by yellowish distillation of urine. There was no history of preceding prodromal symptoms or pruritus, history of medications, no history of blood transfusion or sexual behavior. A patient developed distension for 7 days, elicited by decreased urinary output, which was quantified by decreased amount and frequency of distension was suddenly on. This was a patient by tightening of the clothes and then became generalized, which results distension. There is no history of dyspnea, lying down, or exertion. Patient had developed bilateral pedal edema for 7 days, which was followed by abdominal distension, and no history of facial puffiness or periorbital edema. Then altered bowel habits, melena, metamesis, altered sleep and cycle, altered sexual fever, nausea or vomiting, shortness of breath, anorexia, or weight loss. The past history, patient had an episode of abdominal discomfort and pain in 2021, for which he was diagnosed with some liver disease. All the documents are not available. Patient had taken medical medicine for 3 months and stopped on its own. There is no history of ICU hospitalization and no history of diabetes or thyroid disorder. Patient does not have any operative history, personal history. He is having alcohol use disorder. He is consuming country liquor for 20 grams per day for 2 years, followed by 40 grams per day for subsequent 3 years. 10 accidents for 1 year when he was diagnosed. Then again he started drinking for last 8 months. He's having episode of binge drinking. His frequency of drinking is daily. Last intake of alcohol abuse was 20 days back. He's a chronic BD smoker for 7 years, smoking 20 BDs per day. He is vegetarian by an appetite is decreased. Normal, passes one stool per day, which is normal yellow in color and semi-solid in consistency. Bladder habit decreased once in volume of maturation without any burning duration. There is no history of liver disease in the family. To see my case, 35-year-old male with a history of alcohol intake for 7 years without any comorbidity presented after episode of binge alcohol drink, painless progressive jaundice for 15 generation preceded by decreased output for 7 days, not associated with abdominal pain, melena, hematemesis, or altered sensorium, with prior history of liver disease diagnosed 2 years back.
We'll have.
So,
So you have narrated what the patient has told you.
yes, sir.
What has been your direct question in regarding other causes of liver disease? You highlighted the alcohol.
Yes, sir.
There can always be other causes of liver disease, so I don't really find very much interrogation for other possible causes.
Yes, sir.
Who do you consider and how would you like to clarify this?
Yes, sir. That is with any high risk sexual behavior, any history of blood transfusion, any vertical transfusion. If his mother had any hepatitis B related liver.
Let me just specify the questions you would ask the patient.
Yes.
One is there any history
family. Yes, sir.
Right. And
And history of blood
prodrome you have
transfusion.
mentioned.
Yes,
This
sir.
particular illness, there is a sudden onset of jaundice, so prodromal symptoms. What is prodrome? He's
Uh,
been unwell.
yes,
Isn't
sir.
that a prodrome?
So, low-grade fever, malaise, generalized weakness. These are the considered as a prodromal symptoms which preceded the onset of actual symptom.
See, the word prodrome when you use always is that you're talking about viral illness. So features suggestive of a viral illness, which may be in the form of fever, myalgia, body ache, anorexia, nausea, vomiting, etc. So those are non-specific features. Kind of equate them. We tend to equate them with a viral infection.
Yeah.
So it's certainly worth inquiring. History of blood transfusions, autoimmune disease, autoimmune hepatitis is uncommon,
Yes,
more
sir.
common in ladies, women, but not said. What history would you ask to assess for autoimmune?
Sir, arthritis that leads to then chronic diarrhea and due to colitis or primary sclerosing, primary
Right. Extra hepatic features are normally present in a minority, in a quarter or a third only. So you may have a disease without necessarily any extra hepatic features, but yes, you must interrogate thyroid disease,
thyroid
there
disease.
is thyroidism or similar features, joint skin, oral ulcers, etc. Finally, I think an important cause overlooked which you not about at all is drug induced.
Yes, sir. I've asked any medication.
Needs to be specific. Which medication you ask for?
Sir,
You don't ask people names
yes,
of
sir.
medicine. Ask about
Yes.
they might have taken.
Yes.
What
If
did you get on that?
he has taken any medicine for pain, anxiety, only abuse, tuberculosis.
I mean, but they were not really highlighted. Plus, I think drugs, indigenous medicines.
Yes, that is extremely important.
Or any other symptom of generally being unwell, they take indigenous medicines.
Yes.
They herbal medicines, Ayurvedic medicines, they have the potential of hepatotoxicity. It doesn't really link it with the liver disease, so you will not. You will have to go for it and find out if there is such a disease.
Yes.
Now, alcohol history you have narrated. Could you tell me what like 80 grams per day and 20 grams per day?
Yes, sir. One drink of alcohol, that is 40% hard liquor, considered 45 ml of alcohol.
That is the calculation.
Yes, sir.
What do you ask the patient?
I've asked how much he consumes.
I tell you.
He consumes 200 to per day over the 24 hours.
So which drink?
Of hard liquor, country liquor, that constitutes 40% of.
When you get from the contract vents, people buy it from the contract vents. The Indian made foreign liquor is what all these where the sharab and alcohol is sold, they give. What is the alcohol content of these IMFL products? Because you say 2 ml,
Yes,
and you convert it to grams.
Yes,
you must know the alcohol concentration.
Sir, yeah, hard alcohol contains 40% of the pure alcohol.
Otherwise, you find out what is he drinking. Is he drinking whiskey? Is he drinking vodka? Is he drinking rum? All these have their composition.
Yes,
The blends 28 to 30%. They are not 40%. Right? So most places it is legally mandatory. They can't go below that. It certainly will not go above it. Right? So those you have to get 2 ml of what? Deshi liquor,
yes.
or he goes to one of these TK wala places and gets the liquor from there. So I think it is important to quantify this.
Yes.
Again, duration, how did you verify that it is only 7 years and not 10 years?
Yes, sir. I've asked the patient and then confirm with.
You speak with the parents.
His wife and his brother.
They live with him, the brother and the other?
Yes.
He lives on his own.
No, he lives with his family.
And he drinks outside.
No, he drinks outside with his friends.
How will the brother know? How will the wife know how much he has drunk? Must verify these things because basically believing the patient's word. And generally, studies have shown that most people who drink lost the respiratory. they are consuming to the 30 to 40%.
Yes.
Reliable is it? And then the second, third party who verifies it, direct knowledge of the amount consumed. So unless one will not say, because what is the usual amount of alcohol that will lead to chronic liver disease in men and in women?
Then 20 per day.
So you're talking about the safe and the unlimited. That is the
As
quantity that is permissible, and beyond that is excessive. The quantum that results in liver injury, the amount and duration.
so, as per the last CME that we have attended, as there is no safe limit for the alcohol, and a single.
You're not talking about the safe limit. That is what people can take. You're talking about the amount, minimum amount that he consumes that will result in injury.
The man 20 grams and female 10 grams per day.
That is the safe limit. Below this, they say it is short term. The data suggests that at this, there is very low likelihood of liver injury developed. That when a male or a female develops alcohol-related liver injury, there are many factors involved, not just the quantity of alcohol, comorbidities, obesity, diabetes, liver injury. It happens to have virus B or C, then much lower dose he will develop. And then there are genetic mutations which make a person more vulnerable to alcohol. So these things can be variable, but by and large, erogenic dose, people talk about it at least 10 years of alcohol in the range of 40 to 60 grams per day, and about 30 to 40 grams in women. Women, obviously, everything is much lower. So, what you are telling is, seems to have, if this is alcohol related, is fairly advanced liver disease. And he's been symptomatic with this even some 4 years earlier, only for 7 years. So, are you saying that 3 years of alcohol, he developed the history that you said 3, 4 years ago, he had compensation? That sounds too soon.
Yes.
So either the duration has been underestimated, you that there are pitfalls in the history you take.
Yes.
And how one can try and be aware of it. Once a person has presented with this, then the background information, what all has been the exact duration and the quantum of consumption may not have great bearing, except in the management of AUP.
Yes.
I think all of us should realize that what we are seeing, liver disease, is not the primary. The primary illness is excessive alcohol consumption, despite getting harm, getting damage. He has stopped for 1 year because he was told that his liver is bad, and despite this, now he has gone back to drinking. That's AUD, and that also means to not simply addressing the effects of alcohol consumption. So for that, from that point of view, it is important to know the duration, quantum, drinking habits. Binge drinking is particularly harmful. Anybody else has any other questions on the history?
What Saraswat is saying. One thing is you need complete knowledge of the subject. Alcohol, right? Alcohol and alcohol percentage, alcohol volume, alcohol duration. So from one alcohol, it can have so many sequences from which the question can come. And he specifically asked you the question from himself, wife, and his brother. You told, then he told that they will usually have less information. So now the history is not just an art that you ask him, you take it as a truth. To understand what he's not told, reading between the unwritten lines is also in history that you understand what he's saying, so that frame a next question to him. Is it so? So that you can understand. Getting the from simple alcohol, there are so many things that come. I think Dr. Shaleen is there. He can also that generally on this basis.
Question, Dr. Maunil, is from this history.
You're not able to hear you, Shaleen. Able to hear you.
उनकी तरफ से नहीं, उनकी तरफ से
शालीन, आपकी आवाज नहीं आ रही है।
I'll join again maybe.
Now we can hear you.
Okay. So, Dr. Maunil, am I?
Yes, sir. Yes, sir.
So, from this history, we have come to a conclusion that is it a foregone conclusion that is a case of alcoholic liver disease, or there could be some other possibility in your mind, or is it just that it is alcoholic liver disease and nothing else?
इसी की आवाज बोल रहा हूँ.
Just what no, what he's saying is that from your history, are you sure it is only alcohol or other causes? Basically, elicited history about other causes too much, but or it was not directed, it might have elicited it. But what is your response? Do you think it is only alcohol-related liver disease or other causes?
Sir, I think this is alcohol-related use disorders, as as we have ruled out any drug-induced liver injury and any blood transfusions, any past history of surgery, any history of.
I think clinically you have not history. History.
Yes, sir.
See, you have written painless progressive jaundice for 15 years.
Yes, sir.
So, painless anything, even obstructive jaundice presents as a painless progressive jaundice can present in the back on the background of alcohol use disorder. Is that so? I suggest that one should be always open-minded with regards.
You did not elicit negative history of extrahepatic biliary obstruction. Okay, I'm not a person develop gallstones or an ampullary tumor or pancreatic cancer and develop PHB.
Anything.
Ask history for those things. Yes, please, Shaleen, go ahead.
Shaleen, आप कुछ कह रहे थे?
Yeah, I was just suggesting to Dr. Maunil that we should always be open-minded. Although the history is quite suggestive, abuse disorder is there, but in the presence of alcohol abuse disorder, it may just be herring, and you may have this. Why not some underlying malignancy creeping up now?
Yes, sir.
In this, from his social background and the area he lives in, why not? It's a case of gallbladder which is developing. You may not have weight loss, weight have come so quickly. So these possibilities you should always keep. Whatever it may turn out ultimately, the possibilities should always be kept.
Diagnosis. Do you have a diagnosis on the history and a differential?
Sir, my differential.
You go on to you go to. I think generally what among medical cases we give us your diagnosis, all your possibilities and differentials after the history.
Okay.
And then the examination will add or supplement to whatever are your possibilities. And one need not because the diagnosis depends on the history.
Yes.
It is then corroborated by physical findings.
So based on the, what is your impression?
So, one is having decompensated CLD, secondary to alcohol use disorder, or chronic liver failure, decompensated CLD, yes, viral hepatitis and likely hepatitis B.
On what basis are you offering these? Just go back to the first change saying is decompensated CLD. What is CLD?
So chronic liver
What is
disease.
chronic liver?
Patient is having underlying.
So what are the forms of chronic liver disease? Chronic hepatitis and cirrhosis.
Yes,
Do you think your patient has chronic hepatitis or
he has cirrhosis, most probably.
then why not say that you suspect that? You suspect cirrhosis.
Because he is having long history of alcohol intake, which can turn into state to hepatitis. Also, he had past 1 year. In 1 year back, he had an episode of abdominal pain, and for which he was liver.
What is the most pressing finding or the most important finding we observe? Suggest that there is
Decompensation, acute decompensation.
Why did you mention that?
Yes,
He has significant ascites consistent with liver failure.
sir.
So I suspect a disease supported by the long alcohol consumption, which the patient already has. And one prior episode of possible decompensated alcohol, which we suspect but don't have the information. So we said underlying alcoholic cirrhosis. And you said ACL. Why ACL?
Sir, because in ACLF, as a definition, followed by ascites within 4 weeks underlying chronic liver disease. The patient is having 1 year.
The Basel Asia Pacific Association definition of liver disease. There are cutoffs more than 5 milligrams bilirubin and more than 1.5 with ascites or encephalopathy.
Yes.
So they that suspect. But generally ACLF is a severe form of liver disease and is associated with other organ failures. You have not mentioned the history of any single. We did talk about urine output, but there is no suggestive of failure, hepatic encephalopathy, or other forms of decompensation in your patient. So I think ACLF would be a less likely possibility. How about just severe alcoholic hepatitis?
Yes, is most important because Dr. Maunil, I would say that his disease 3 years back, maybe I had a just simple episode of acute viral hepatitis which cleared, and now since he had a binge drinking and he's a chronic alcohol intake disorder is there, it as Dr. Saraswat of acute alcoholic steatohepatitis. So that differential should always be there.
In severe hepatitis, in chronic decompensated liver disease, you will not have an abrupt, rapidly rising bilirubin. History of jaundice and bilirubin has gone up and it's become deeply jaundiced. That does suggest severe alcoholic hepatitis, which may be superimposed on underlying alcoholic cirrhosis, or it may just be that he has a relatively normal liver and a very severe episode of acute alcohol-induced hepatitis rise to jaundice. The fact that ascites, edema, significant argue alcoholic cirrhosis with superimposed severe alcoholic hepatitis. These will have implications on your management decision.
For the sake of based on history or examination, can ACLF be diagnosed?
Suspected and proved by investigations, because the ACLF diagnosis is demonstration of organs, and there are clear cut failure biochemically according to Eason and Basel. They are different. One suspects when there is clinical evidence of, say, urea, overloading, that there is other organ failure. But whether that fits the criteria that has been laid down by the different bodies, CT of ACLF has to be verified by investigators.
So yes, there was oliguria and edema. Say that clinical, there is a possibility that it could be ACLF.
I'm saying that is a lower possibility because the other florid features of ACLF, like complications of ascites, azotemia, or encephalopathy, bleeding, etc., are not there. But you have a history of I would keep that in mind. I would look at the blood report. If I get a normal renal function, then it really may not be something that I'll suspect as ACLF. The idea for ACLF have to be met. And within my rights to suspect ACLF here, but is it the first most likely possibility? Alcoholic hepatitis with possible underlying cirrhosis is my first possibility. Severe alcoholic hepatitis alone. I think, and the third would be ACLF.
Let's move on to
Yes. Going to general examination, he is conscious and oriented to in person. He is moderately built and nourished. His performance status is 1 ECOG. BMI is 18, height is 170 centimeter and weight is 52 kilogram. His pulse is 82 per minute. Blood pressure is 108 by 7 millimeter of mercury. Temperature is saturation is 95% on room air and respiratory. Icterus was noted over the sclera. No pallor, generalized neuropathy, clubbing or cyanosis. No parotid sarcomastia or testicular atrophy noted. No loss of axillary hair. No spider nevi. Bilateral pitting edema noted over the lip. And oral examination, tongue was wet and no mucosal lesions seen. On inspection, abdomen was present, bilateral fullness present in the flanks. Umbilicus was center flat. No dilated veins. Signs and sinuses were present. Anal orifice, no visible cough impulse. On superficial observation, no normal temperature or no tenderness was felt. Cannot be appreciated due to ascites. Abdominal girth was 88 centimeters at the level of umbilicus. On percussion, dull not over all the regions of the abdomen. Fluid thrill was present. Liver span cannot be appreciated because of the. However, liver dullness started from the fifth intercostal line. On auscultation, boils also could not be appreciated. No venous arm or groove was heard. On digital rectal examination, perineal skin is normal, no sinus, fistula, hemorrhoids, normal anal tone with adequate squeeze. Rectum was collapsed and empty. Finger glove stained with a yellow colored stool. No nodules were visible, that is normal shell. On bilateral air entry was equal and no added sound. S1, S2 heard. CNA examination, person was oriented to time, place, and person, and no asterisk was noted.
That is, what is asterixis?
Asterisk is flapping tremor, that is grade 1 hepatic encephalopathy. When
Asterixis present means grade 2.
yes,
What is that? How do I elicit? Can you?
Yes.
What is asterixis?
yes, as to flex the extend the both the hands and as to extend the wrist. If the patient has
And then
if patient is having asterixis, then he have a flapping tremors.
Hyperextension.
so what happens in flapping tremor?
This suddenly it'll drop and then it'll go back up again. Suddenly it'll drop. He's waiting or he keeps trembling. That is not a flex.
Specific for liver disease?
The sign of asterixis, is it specific for liver disease?
So which other conditions have it in?
It's like that. Correct. Other
Liver failure.
Yes,
Liver failure is one. Failure, respiratory failure. In people with these, you can also get an asterixis. And so in the see you guys have liver disease, so you will consider it as a sign of liver failure. But people can have COPD and liver disease, then one does say that this is not important.
यूरेमिक एनकेफेलोपैथी में भी होता है.
In uremics, in your respiratory failure, you can have the lab. And I think just go back to your first thing. In your sign, you said moderately built and nourished. Your BMI is 18 kilogram per square meter. Look at the weight, 52. So do you think is moderately malnourished?
severely malnourished.
Yes, malnourished
Yes,
because BMI below 18 is severe malnutrition.
Yes.
That is one. Now again, can we calculate the BMI in a guy who has moderate ascites?
Yes.
So how do you do that? Is there a way to estimate dry weight in them? Most guidelines talk about it. It is people will have ascites, and from whatever weight you 5% for grade 1, 10, and 15% if it is grade 3, 10 ascites. Have any idea about grading of ascites? Grade 1, 2, 3, what is it?
So, mild, moderate, and severe ascites.
What do you call mild, moderate? The description of grade 10s. Tense distension is that the whole abdomen is tense. You can't get, you might get a thrill, but you will not get shifting dullness. The whole abdomen will be tense. The skin may be shiny and stretched. Grade is tense, grade 3. Otherwise, grade 2 and grade 1 is something that is considered only as shifting dullness.
On ultrasound.
Using water fluid thrill, moderate distension, assume it's a grade 2. So 10%, like you subtract 5 kg from that for the cycling. And if there is needle edema, if it is up to the knees or gross edema, then you subtract another 5%. Right? So these are arbitrary
Of the been suggested.
Standard guidelines. You need to apply those before you calculate.
52
Needle edema coming up to the shins, ascites, you're going to subtract of his body. Again, bring into something like 7-8 kilos if you decide.
42, 40, 47, 40, 44, 45 kg. You make your BMI 16 or something. right? Nutrition. And then you haven't really talked about any specific types of nutritional deficiencies. Alcoholics is probably not consuming too many calories. What are the nutrition?
Sir, oral cavity, mucosal lesions, and vitamin B12 deficiency, oral ulcers, macroglossia, sir. Then
Macroglossia get in cretins and hypothyroids, not macroglossia. You're talking angular stomatitis. Deficiency. But the most common deficiency is thiamine deficiency, B1. Every single once he comes into hospital, intravenous thiamine supplementation.
it's to prevent warning is encephalopathy.
Right. So severe thiamine deficiency is often present in them because they are not consuming this. Plus, when you give them intravenous carbohydrates or glucose infusions, which many people get in the, it precipitates severe acute thiamine deficiency, which you know as beriberi. So there's wet beriberi, high beriberi. You can have a high output, congestive failure, arrhythmias will be life-threatening. And the other thing is Wernicke-Korsakoff sepsis can be precipitated. So deficiency has to be suspected. It is difficult. Clinical features of advanced deficiency are present. So victim is all of these thiamine supplements. Zinc deficiency, other micro. This is just by the way because once you're looking at it and you're talking of nutrition in a guy with this problem, then these are some of the features that specifically one should look for and mention or absent. We really don't have much on the vitamination as a nutrition. At this now, can we come to what is your diagnosis and how do you manage to proceed to investigate?
So my diagnosis will be, sir, decompensated chronic liver disease.
Do you have a diagnosis?
Some reason.
Why is the diagnosis? Whenever there's a clinic, you can't do a clinical presentation without giving. Why is the diagnosis missing? There has to be a diagnosis, which may be a provisional or a clinical diagnosis with, if you're not sure, you have a differential. A syndrome, etiology, complication, comorbidities, all of these come in the diagnosis, and then accordingly you plan your management. So probably in the future, I would any case presentation result in a clinical diagnosis. What would be your diagnosis as of now in this?
Decompensated chronic liver disease. High use disorder. My main differential would be severe alcoholic hepatitis. Third would be, sir, ACLF.
Differential नहीं पूछ रहे sir. Now you have to confirm on your diagnosis. Single diagnosis आएगा.
You can specify.
CLD secondary to alcohol.
The pointed out in the compensated chronic liver disease does not fit here because you have not there is no other features of chronicity that you have found other than ascites, which is of short onset, and there is deep jaundice. Under chronic decompensated liver disease, you will have a shrunken liver, spleen, you may have moderate ascites and moderate jaundice. If he has deep jaundice, which you can assess by looking at the sclera and examination, if this is deep jaundice or it's mild jaundice.
Deep jaundice. Dr. Maunil.
That would be for severe alcohol.
Hello.
Yes, sir.
Dr. Maunil,
yes, sir.
I would like to intervene here. That how does the physical examination, does it alter your diagnosis that you made on the history alone? And second, first diagnosis would be acute alcoholic steatohepatitis. How would you support or refute my diagnosis? From your history and physical examination, I would put acute alcoholic steatohepatitis as my first, followed by the CLD that you have made. As Dr. Saraswat had said, there is hardly any signs or any in the history or physical examination which are supportive of ongoing chronic liver disease. So please refute or support my whatever my statement that my first diagnosis is acute alcoholic steatohepatitis.
Yes, sir. As the patient is a liver disease which was diagnosed 1 year.
How do you know he has got an underlying disease? Dr. Saraswat just pointed out the jaundice and the ascites are only of 15 days duration as per your history. And he had an episode of some liver disease in the past, which we have very vague information about. So on the basis of these two findings of chronic liver disease, although it may be present, I'm not ultimately it may turn out to be that, but on the basis of whatever you have said, it is not you don't have very solid data to support that it's chronic liver disease. I would say there was some liver disease in the which may not have any connection to this. Now he has decompensated. Now he has developed symptoms. It could be an episode of acute alcoholic steatohepatitis. There is no splenomegaly, no GI bleed, and on your examination there are no findings of chronicity.
It is part of acute severe alcoholic hepatitis. Acute and chronic, I think, are generally not avoid alcohol. So it's mild or severe alcohol related hepatitis. History of short duration of jaundice and rapid appearance of ascites in favor of an acute event, which is the major component of the illness. Is there an relatively compensated chronic liver disease pre-existing? There is no strong evidence or against it. One can suspect it because of the prolonged history of alcohol consumption. If you had found a shrunken liver, if you had found a big spleen, if there had been history of previous endoscopy showing large varices, or he had had variceal bleeding, then I would be on stronger ground suspecting underlying pre-existing liver disease. Right? When you don't have it, then making it your first diagnosis is a bit difficult. And management will depend on if you suspect that this severe alcohol hepatitis, which is decompensated, then it's natural from decompensated liver disease. You plan your management is your prognosis for this patient. So I guess we need to move on to investigation and management a bit more quickly. So I would say that let us working diagnosis should be severe alcohol hepatitis with or without liver cirrhosis. Okay, CLF should be verified on investigation. Tell us how will you investigate the severity of liver disease and plan management?
Yes, sir. Sir, I would like to get two sets of investigation part. First, blood investigation, which includes liver function test, including and renal function test with electrolytes and complete hemogram, and also to extend my clinical examination, I would like to get you to know the status of the liver, spleen, and ascites. Support the if patient is having underlying.
Just enumerate the tests. Justification of the test can now. Let's go. Order of priority. Which are the sets of tests that you will ask for as a first set of tests in this patient?
Blood investigations first, which includes liver function test, then which also gamma glutathione transferase with renal function test, electrolytes, coagulation profile, INR, complete hemogram, sir, and to extend my clinical examination, USG followed by portal vein or Doppler to know if there is any dilatation or polytals or know the any flow the portal vein
Why
system.
you want to be done, we can see when we are discussing it. You would like an ultrasound of the abdomen.
Yes, sir.
To look for the liver, hepatosplenomegaly, ascites, and hypertension.
Yes, sir.
What else? That is all.
Then followed by upper GI endoscopy, sir, to look for varices or any and there will be the primary reasons. And
cycloid examination. Yes,
sir.
I think new will be investigated in every patient, so that should. And viral markers. You can't rule it out. You may not have a high index of suspicion, but suppose you get an HbSAg or anti-HC positive, then it completely changes your management, or at least adds another. So while you may not be suspecting it strongly, it certainly must be done in all such patients with acute onset of jaundice. EC, and could this be acute presentation of short onset jaundice, plus PM anti-HAV, anti-HEV as well.
Yes.
Viral markers to make sure there is no hepatic component to alcohol injury. Strongly suspect. So we have.
Yes, sir. At this point in time, sir, we say autoimmune markers. We would like to, or it will be second set of investigation.
I guess
I would probably just stick with these autoimmune markers unless there's a pointer in the history. Thyroid, he has joint disease, he has skin markers. I wouldn't ask for them automatically.
Yes.
Especially in the view of the strong history of alcohol, continuing up till the onset of jaundice. 20 days was when he last consumed, but in jaundice for 15 days. So till within 15 days he's been taking alcohol. And I think the first suspicion always will have to be alcohol-related hepatitis. In addition, I would like to rule out viral because it is
Quite, and there's a so let's see the reports.
Yes.
Click कर इसको click.
His on the blood parameters, sir, WBCs are higher side, 14,000 with news of 74. Platelets are lower side, 57,000. His RFT is within normal limit. His total bilirubin is 9. And direct component is 3.5. OTPT are mildly increased. OT is increased, PT is within normal range.
We don't read them all. We have already halfway through all of them. What are your comments? What are the points that are you can talk about what? Alcohol-related hepatitis and chronic liver disease. What are the features in favor of either of these possibilities?
Yes, sir. Altered population hyperbilirubinemia suggests
What altered is 1.3?
one mildly increased. Yes, sir.
Up to 1.5 is considered normal. Liver failure is say when INR is more than 1.3. 1.3 would not be too concerned about it. Yeah. So,
Hyperbilirubinemia and pointed toward the underlying alcohol hepatitis, sir. And
you're now between hepatitis and cirrhosis.
yes, sir.
So what are the features here that tell you that I would, these are favor cirrhosis over hepatitis?
SGOT compared to SGPT, the alcohol
etiology.
etiology.
You have anywhere in the history, and this is consistent with that. So it doesn't differentiate between cirrhosis or hepatitis that much once it's alcohol. Other etiologies you might suspect. Low platelets, low alcohol suggests hepatitis or cirrhosis.
Cirrhosis.
Potential cirrhosis. You should say that these features suggest that there may be cirrhosis. 15,000 white count, I tell you.
Patient may have underlying sepsis in terms of if we do paracentesis.
We never told about the fever. We never had fever.
If
suspecting infection.
Yes, sir.
And the first thing is it suspects severe alcoholic hepatitis. Aseptic infection, cytosis, polymorph, feature of severe acute alcohol-related hepatitis.
Yes.
Right. So that and infection is something you can never know. I would be surprised if I find no infection because this is also consistent. So now what else? You said ultrasound. Do we have the ultrasound?
On the USG, there is an altered ecotech with hepatomegaly and no HBID, and spleen is mildly enlarged, 12.4 centimeter, and moderate and on the Doppler, sir, total vein diameter of 12.7, that is mildly enlarged, however, not significantly, and velocity of total vein is reduced 16 centimeter, which is usually 20 to 30 centimeter per second.
So imaging features suggest cirrhosis or hepatitis.
It suggests cirrhosis.
What?
With portal.
Is there portal hypertension? What is the portal vein? 13 millimeters is normal or abnormal? Are they collaterals?
No.
So what features are size? Barely increased. Normal steel is 8 to 9. Mild splenomegaly is not palpable. So how does it favor long-standing portal hypertension? Acute onset of this would be, we haven't got the cytic fluid report, but a high sag ascites here would be hypertension. But of acute onset, short duration, the chronic features are not there.
Yes.
See?
Large liver
Small
suggests
large biopsy will tell us, but this liver side, advanced cirrhosis, even in alcohol, they would be relatively shrunken. So histology is a cirrhosis suspect just
in this.
all in all, not very strong evidence in favor of established or advanced cirrhosis.
Yes.
Much of it seems to be severe alcohol-related hepatitis.
And sir, development of ascites, could it be due to portal hypertension or due
Due
to
onset of portal hypertension in these people, or acute worsening, not necessarily onset. Portal hypertension, severe side disease, moderate aside disease.
yes.
So, I mean, on histology, I would be surprised if definitely be hepatitis with fibrosis, maybe F2, F3, F4 fibrosis.
This is what I would expect in this.
Dr. Maunil, I would just like to point one thing. Hello?
Yes, sir.
That
Yes, sir.
alcoholic hepatitis and cirrhosis, they are not two watertight compartments. As Dr. Saraswat was talking about liver biopsy, in 60 to 70% cases of alcoholic hepatitis, steatohepatitis, 60 to 70% patients will have some evidence to suggest chronic liver disease in terms of bridging fibrosis or some early nodule formation. However, from your ultrasound findings, the degree of portal hypertension doesn't appear to be severe. And an enlarged liver is a very strong pointer towards an episode of alcoholic steatohepatitis rather than decompensated cirrhosis. And that is further supported by your upper GI endoscopy findings.
Yes.
Grade 1. Yes, grade 1 to 2 varices can be present in alcohol hepatitis also. Grade 3, 4 varices with red color sign would be.
So small varices can be part of hepatitis. Okay. So what next?
You've done this. Did you have an ascitic fluid report also to show us?
No, no, but in alcoholic, sir, we can have hypertension.
Alcoholic can have increase of values of it. Then what is the significance?
100 is normal.
Mileage 100 is normal. 107 is normal.
Life is normal.
Life is range around 100 to 300.
How do you explain the thrombocytopenia?
Yes, sir.
How do you explain the thrombocytopenia? Alcoholic hepatitis patients usually have platelets on the higher side, pure alcoholic hepatitis. Is there any explanation?
Being or 12 said something.
Splenomegaly.
The cause of thrombocytopenia is only splenomegaly, or what is the why does liver disease have thrombocytopenia?
So, because of the portal hypertension.
Was in splenomegaly,
Yes, sir.
was in hypersplenicism and splenic sequestration. One mechanism. But probably the more important mechanism is in cirrhotics, you have deficiency of thrombopoietin. Thrombopoietin is made in the liver. So as a result, you may have thrombocytopenia. So I think to answer Dr. Shaleen's question, I would think that thrombocytopenia is in presence of underlying in this individual, and rather than hypersplenism or the acute alcoholic hepatitis. Pure alcoholic hepatitis, normal platelets or slightly on the upper side of normal, I would agree on that. Yes. But then I would actually repeat the counts and see if you have consistently low platelets, then I would think in terms of liver cirrhosis also in this person. Now you have done this, so you have got a diagnosis. You strongly suspect alcohol-related etiology. How will you proceed to manage this patient?
Alcohol-related steatohepatitis. First, we would like to mobilize the fluid with the diuretics, albumin, and vasoconstrictor 30% can be given. Along with that, corticosteroids should be started.
One by one. So first thing is managing the complication. Secondly, trying to manage the underlying. The complication you're talking about is ascites. On that, you want diuretics
Serum albumin was low here, right?
Yes, sir.
2.6.
2.6.
Albumin infusion with white early pressing here. You have renal failure.
Sir, urine output and this value, the hypovolemia, if we get a urinary sodium level, then we get to know that how much is the sodium aspiration. If it is 30 millimole,
Early pressin is indicated in which set of patients with ascites?
low hyper.
Early pressin is a treatment for hepatorenal syndrome. There has to be failure. But here in this picture, it appears that there is renal failure. And more than one reading, looking at other components one might want to see, reporting oliguria. I don't have any idea what urine output. Is he at 200 ml per day urine output?
Yes, sir. Is we have not quantified before the admission. After the admission, he was immediately started with the tele.
What basis? When before you start?
Patients.
No.
So what was the basis? Why did you start early pressin in this?
Is the question that in the management of ascites, when is the role of terlipressin? As Dr. said, if you have evidence to say that there is hepatorenal syndrome, then it is there. But whatever values we have, there is no renal dysfunction.
Hepatorenal syndrome, how will you establish?
2.5.
Today, if anybody follows the current definition, this is what everybody must be doing for an AKI, acute kidney injury, type. It is a 0.3 milligrams per liter rise over a previous baseline. I have no idea, you've given us only a single value.
Yes.
Suppose 3 days earlier or a month earlier it was 0.8. Today it is 1.3. Then I will suspect acute kidney injury as the HRS type. So those infections have to be provided before you go ahead on treatment. The other thing is you look at the urinary electrolytes. How does urine sodium determination help us in making the diagnosis or between the various forms? AKI, acute kidney injury, can be pre-renal, it can be hepatorenal, it can be acute tubular necrosis, or intrinsic kidney disease, a diabetic with nephropathy, obstructive prostate involved, not in this person, but otherwise. So these are acute kidney injury. How will you differentiate between them?
So, Dr. Before we go on, for students, can you please explain AKI and HRS?
AKI is a broad generic term in which there is acute kidney injury. Now that can be, as I said, for these 4 or 5 can contribute to a deranged renal function. One is pre-renal. The patient is underhydrated, underfilled. He has not been taking enough. He's been vomiting. He's pre-renal. So he's hypovolemic AKI. The patient who has normal filled up volume yet has low urine is hepatorenal, where the pathophysiology is a spasm of the intrarenal arcuate arteries, and as a result of poor perfusion, poor glomerular filtration, and low output. Acute tubular necrosis, when again there will be oliguria because of whatever reasons, then there can be intrinsic kidney disease or post-renal due to obstruction. Okay. So there are various components of acute kidney injury, and a person can have one or more of these components. So before you at least make an attempt to differentiate between. So one is urine sodium. I do a urine sodium. How does it help?
Sir, escalation of more than 30 millimoles of urinary sodium is considered to be normal. If it is less than 30, in cirrhotics, it is between the range of 10 to 30 millimoles of the urinary sodium levels. If after giving diuretic therapy, we should assess the urinary sodium levels, and
just diagnose one of you have a patient with a creatinine of 1. This value was 0.8, and how does it help me in different?
if it is less than 30 millimole, then it can be due to hepatorenal syndrome. If it is more than 30,
I think that number is completely off. Less than 10 can be hepatorenal, it can be pre-renal. There's no differentiate on this between pre-renal and hepatorenal. If it is more than these values, then it could be normal, or if you are very high, 110 and there is AKI, I could suspect acute tubular necrosis, which will have to be verified by getting urine sediment examined. So that is what it would. What you're left with is there is pre-renal and hepatorenal, which you can't distinguish on urinary sodium. Common causes. How do you do it?
Shaleen, you wanted to say something?
Yeah, Dr. Maunil, just I would like to correct
Yes.
that when you are talking of electrolytes, you don't use millimoles, you use milliequivalents. And as Dr. Saraswat rightly pointed out, 10 is the cutoff. And he has given you what is the difference. Like if it's pre-renal, it would be less than 10, the sodium excretion. Secondly, even when actually the term HRS is a very kindness term. Now we talk in terms of acute kidney types of acute kidney injury that Dr. Saraswat described. So HRS is not a valid, very valid term, which is strictly speaking not used in today's literature as when we talk about cirrhosis with renal dysfunction. We have to talk in terms of acute kidney injury, and you have to differentiate like pre-renal sodium would usually be less than 10, severe vasospasm, which actually is the pathophysiology for the term older term of hepatorenal syndrome, and again there would be sodium retention less than 10, and above 10 would be like acute tubular necrosis patients would have high sodium excretion, and most of these patients would have hypervolemic hyponatremia. That is, the volume would be the serum sodium, that is, the body sodium would be either normal or higher, but because of volume retention, it would be hypervolemic, relative hyponatremia. So you have to be careful about your units, that is, it should be milliequivalent. Secondly, talk more in terms of acute kidney injury as per the standard guidelines. And then, so urinary studies are very important when you are evaluating a patient of cirrhosis, especially with large volume ascites. These were my comments.
I think it's coming back to the management.
Guides discuss कर लेते हैं बस.
We have to treat ascites. Now, ascites management in itself is a full discussion, so let's not get into the details. But I think automatic use of terlipressin is just not on. You have to prove AKI before you use terlipressin, and we can respond. And there are ways we can discuss.
And terlipressin is not any. We have seen a lot of anemias, diarrhea with terlipressin, so it should be used only if you have definite indication of acute renal dysfunction secondary to underlying cirrhosis or bleeding.
Now you have this patient here. How do you assess the severity of alcoholic injury? Do you use corticosteroids in everybody with alcohol-related hepatitis, or in which substance you consider corticosteroid therapy?
The alcoholic hepatitis, we use
Will score is not for quantifying baseline. It is for quantifying response to treatment.
Yeah.
So it's a separate thing. You at a baseline, what are the scores? There are two important scores that you to decide severity.
Yes, DMF.
Only severe alcoholic hepatitis is should be considered for steroids, and then you have to show it is severe and to exclude contraindications before you offer steroids. So first, tell us what is severe alcoholic hepatitis, and then we.
Severe alcoholic hepatitis, we first quantify with the DMF score, sir.
MDF, Madrid's discriminant factor.
Discriminant function, DF. So any idea how it is calculated? Very easy score.
It includes age, bilirubin, and
ABIC score बोल रहे हैं. 4.6 into difference between patient and control thrombin time, not INR value, thrombin time plus bili. So here, what is the prothrombin time is not mentioned, 1.3.
1.3.
So it is 12, 1.3, 4 seconds, multiplied by 4.6, plus bili is 9. So it's below 32. A DF of 32 or above is alcoholic hepatitis. So this person, according to what you calculated, his DF is going to be below 32. So that is one way of what are the other?
a big
Acute hepatitis score, JST-SS, and MELD is the standard model for end-stage liver disease that you would do. You would apply all these, and there are cutoffs to diagnose severe. If it is not severe, he is not a candidate for steroids. Right? Quickly, we're probably out of time. So just to summarize, the contraindications to the use of steroids would be
Systemic rectal peritonitis,
acute infection, any active